So, good morning, everyone. I think we will start. So I would like to thank you for being present to that session. Today it's a session that will be dedicated to MRDs. We will be talking about MRDs as an alternative to CPAP treatment. And today we have the pleasure to have two very important speakers to hold that session. So we have Professor Peter Cistulli, who is who will start the session. He is the director of the Center for Sleep and Health Research in the Department of Respiratory and Sleep Medicine at the Royal North Shore Hospital in Sydney. He's also the he's also heading the discipline of sleep medicine with the Faculty of Medicine of Sydney, and he's been active in clinical research for 20 years old in the field of sleep, and he's been a pioneer with the use of oral appliances as an alternative to CPAP. So we are really delighted to have him with us today. Then we'll have Professor Jean-Claude Meurice, who will be presenting the second part of the workshop. He's the head of the Department of Pneumology of the Poitiers University Hospital in France. He was the former president of the Sleep Society, the French Sleep Society. And he's been involved as well in the sleep field for many years, for 30 years, and he's been involved in research. And in one of the research that we held as Resmed for the MRD, the Narval MRD, which is called ORCAD, and is going to present today some of those results. Is one of the main member of the committee, scientific committee of this study. At the end of the session, we'll have a small hands-on part where you will be able to see the Narval product and manipulate it. So I wish you a good session, a good workshop, and I'll speak to Professor Cistulli. Thank you.
Thank you, Corinne, and it's a pleasure to be here today. So as Corinne said, I'm from the University of Sydney in Australia, and my job today is really to give you a sense of the state of the art, an overview at least, as I see it. Let me start with some disclosures. So I hold an academic chair at the University of Sydney, which is endowed. It was funded by Resmed, and I receive research support from both CPAP and oral appliance companies. So we're here today really talking about an alternative to CPAP, but it's important to understand the place of CPAP in the field of sleep apnea. It's now nearly 40 years since the invention of CPAP. This is actually the first patient in the world who went home with a CPAP machine. You can see it was a very cumbersome, very heavy machine, and we can ask the question, why is it still here 40 years later if it's such an invasive treatment? And the answer is because it's such an efficacious treatment. It can fix sleep apnea no matter where the obstruction is. These are 3D MRI reconstructions of the upper airway at increasing levels of CPAP, and you can see the diffuse dilatation of the airway. And that is the challenge for all alternative therapies. How can they produce this diffuse enlargement of the airway? What might be less familiar to you is that oral appliance therapy as a field is also quite old. This is a very early study by Professor Meurice, who talked about the Esmark appliance, a one-piece appliance that produced mandibular advancement. So oral appliances have actually been around for a long time, but they're still finding their place in the management of sleep apnea. Now, we have a number of different oral appliance designs. There are literally 100 or so. I've only shown 6 here, and apologies if I'm not showing your favourite one. Essentially, the ones that we're talking about today are mandibular advancement splints, MAS, but in this talk I'll be using the term mandibular repositioning device, MRD. So they have emerged as the leading alternative to CPAP. Within the European Respiratory Society Task Force, there was a publication in 2012 that recommended their use for mild to moderate obstructive sleep apnea, and I think that largely reflected the state of the literature back at that time. However, the current literature has expanded, and there is now clear utility of these devices even in severe sleep apnea. And so the second recommendation there is if they're preferred to CPAP or in the case of CPAP intolerance or failure. And this is from the practice parameters of the American Academies of Sleep Medicine and Dental Sleep Medicine, published in the Journal of Clinical Sleep Medicine in 2015. So they have removed the reference to mild to moderate and can be used in all cases. Now, the first question is what does MRD do to the upper airway? And there are many imaging studies that have assessed the anatomical effects. And I've very much simplified it here. We can all understand that mandibular advancement protrudes the tongue and enlarges the airway behind the tongue. But when you look at MRI scans, things are a little bit more complicated and somewhat counterintuitive. So here we have two axial slices of the same patient through the level of the velopharynx, that is the level of the soft palate, not at the tongue level. And in the middle here, this black area is the airway with a little blue mark at the edge. Now, here are 3D reconstructions, both in the anteroposterior and lateral dimensions, and at the bottom we have the volume of the upper airway. So we put the MRD in place, and the volume of the airway increases, and notice that the enlargement occurs in the lateral dimension at the level of the soft palate. That is the predominant action. There's also an anteroposterior movement as well. So in some ways, mandibular advancement splint therapy does produce diffuse enlargement of the airway, not exactly like CPAP, but similar. So how well do they work at reducing the AHI? I'll start with one of our own studies. This is a compilation of multiple smaller clinical trials from one centre using one particular mandibular advancement splint. And you can see it was 425 patients, and we defined response using this legend here. A complete response was a return of the AHI to less than 5 in blue. As we liberalise the definition, we can say an AHI of less than 10. And again, if we liberalise further, we can say a greater than 50% reduction in the AHI. And you can see across all patients that 2/3 of patients will achieve the minimal criteria for a good response. But even as you develop a more stringent definition, a rigorous definition, nearly 40% of patients will achieve an AHI of less than 5. When we look at the baseline OSA severity, you can notice the blue column gets smaller as sleep apnea severity increases, and the green column increases. That is that there are less complete responders, AHI less than 5, but still many people, 70% of patients with severe sleep apnea, will get a greater than 50% reduction in the AHI. However, it does mean that about 36% of patients don't get a good response. That is, it's less than 50% reduction in AHI. Now, I hope this slide doesn't turn you off, but it's really just to make a simple point. This is a meta-analysis of studies looking at the effect of MRD on AHI, more than 40 studies, and this is the forest plot here on the right, and you can see that the average reduction in AHI is in favour of oral appliance, nearly across all studies. So there is no question that MRD reduced the AHI. This slide is data from our own randomized crossover study where we compared CPAP and oral appliance in the same patients, 108, but this is just the subgroup who had severe sleep apnea at baseline, an AHI greater than 30. And what you can see is that 21% of them, 1 in 5, achieved an AHI of less than 5. More than a third achieved an AHI of less than 10. So even in severe sleep apnea, oral appliance therapy has an important role. Now, this is a meta-analysis of studies that have compared CPAP, the gold standard, and MRD, the main alternative. And here is the forest plot with the 0 there. And you can see that nearly all studies show that CPAP is superior at improving the AHI. All these average AHI reductions are on the right-hand side of the 0. But notice that the mean difference, the pooled mean difference, is not huge. We're talking about an AHI reduction of 6 compared to oral appliance therapy. In some phenotypes, like positional sleep apnea, there are studies that show that MRD are equally efficacious to CPAP. That is, they both achieve the same reduction in AHI. So these are the positional patients with both MRD and CPAP achieving an AHI of less than 5, whereas non-positional OSA MRD therapy is not quite as good. This is a different meta-analysis. It's a network meta-analysis that allows comparison between treatments, even when they weren't directly compared in the primary study. Again, the message here is that CPAP is superior to other therapies at reducing the AHI. However, when we look at other outcomes, such as the Epworth Sleepiness Score, a measure of subjective sleepiness, we see that CPAP and MRD are really no different in terms of the improvement in Epworth Sleepiness Score. So this really starts to open up the question about whether there is a difference in health outcomes between the two treatments. And so I think the field is starting to realise that the AHI alone can give you a false sense of reality, and we need a more holistic interpretation to compare the performance of both treatments. So we need to look at the effect on symptoms, on more objective health outcomes, adherence, patient tolerance, acceptance, convenience, and cost. So I'm going to fairly quickly go through this, but you can see from the table here that I'm listing a series of outcomes, in this case symptomatic outcomes, and we have a column for CPAP and a column for MRD, and the number of crosses is the strength of treatment effect. And what we're doing is comparing these two columns as we go down these symptoms, and what you will see is that there is very little difference in the improvement that one sees in snoring control, subjective sleepiness, neurocognitive function, quality of life, and mood. What about when we start to look at more objective health outcomes that are not prone to placebo effects? Well, a similar story emerges. Objective sleepiness, measured in a variety of ways, is similar between the two treatments. Reaction time or psychomotor speed is similar. Driving simulator performance has been shown to be similar with both treatments. And cardiovascular outcomes also seem to be similar. I'll go into that in a little bit more depth, and also mortality. So let's look at some of these cardiovascular outcomes. Of course, the best studied of these is 24-hour blood pressure. We know that CPAP is effective at reducing blood pressure by a few millimeters of mercury. This is in fact a meta-analysis performed by a group in Zurich, and they looked at 51 studies involving almost 5,000 patients with sleep apnea. One part of the study looked at CPAP versus inactive control. That could be sham CPAP or a placebo tablet. And you can see that CPAP produced a reduction in systolic blood pressure of 2.5 and diastolic blood pressure of 2. When we look at oral appliance therapy versus inactive control, usually an oral device that does not advance the mandible, you can see very similar reductions in both the systolic and diastolic blood pressure, and there was no difference between the two treatments in their reduction. And that's shown on this slide here. It's a smaller number of studies that have directly compared CPAP and oral appliance therapy, but here is the forest plot for systolic blood pressure at the top, diastolic blood pressure at the bottom, and you can see that, the difference between CPAP and MRD is not significant in terms of blood pressure reduction. What about other cardiovascular markers? The main ones that have been looked at can be considered surrogate cardiovascular markers rather than clinical endpoints. One example is arterial stiffness, which is thought to be a precursor to vascular disease and atherosclerosis. This has been assessed in a couple of studies. One was a randomized crossover study that we performed with CPAP and MRD over 1 month, and we found no difference in the improvement in arterial stiffness. The bottom one is an observational study of MRD alone over 1 year, showing a significant decrease or improvement in arterial stiffness. Another important surrogate cardiovascular marker is endothelial function. And this has been looked at in a number of studies. The top one is an observational 1-year study showing an improvement in flow-mediated dilatation with MRD. The next study from here in France was a randomized crossover study, a small study, a pilot study of 15 patients with CPAP versus MRD, 2 months, showing no difference between the treatments. And that study led to the bottom study, which was a large multi-center crossover study of 150 patients with severe sleep apnea. And unfortunately, there was no improvement in endothelial function in this study, so it was a negative study. However, one point to note is that only about 20 to 25% of patients in this study had abnormal endothelial function at baseline, despite having severe sleep apnea. Another surrogate marker is heart rate variability, which tells us something about the sympathovagal balance. We know that in sleep apnea there's sympathetic activation. And across these studies, both CPAP and MRD have been shown to produce improvements in sympathovagal balance to an equivalent extent. So MRD is non-inferior to CPAP. Now, arguably the most important clinical outcome is death, and we know from this observational study from Spain that if you have untreated sleep apnea over a 10 to 12 year period, you have a markedly increased risk of dying, 3 to 4-fold compared to people who snore but don't have sleep apnea. But in the blue dots here, so that's the red is untreated. In the blue is with CPAP, and we can see that CPAP is associated with a markedly attenuated mortality risk. Now, of course, this is observational data, not randomized control data, and so we have to be careful about the interpretation. However, I do want to point out that there is a similar study for MRD from the United States. This was published about 5 years ago, and it's a clinical observation study from a clinic where CPAP was the primary treatment, and they only used oral appliance therapy in CPAP failures. And in this study, they ended up with 4 groups from clinical practice. A group who didn't have sleep apnea at baseline, they managed to follow them up. Within the group of severe OSA with AHI greater than 30, they had a group who was effectively treated with CPAP, a smaller group who went on to MRD treatment, and then another group who refused or failed both treatments, and so they were untreated. And this graph here is the survival probability, so it's the opposite of the mortality graph that you saw before. And here is the graph for untreated obstructive sleep apnea. the probability of being alive reduced over a period of 6 to 8 years, such that the hazard ratio was 6.5-fold compared to individuals without OSA. But notice that whether you had CPAP treatment or MRD treatment, you had the same reduction in risk, which was similar to the non-OSA controls. So no difference between the two treatments. Now let's move on to adherence. We often know from our clinical practice that adherence to CPAP is not optimal, but how does it compare to MRD? This study, again from France, was quite interesting in that it looked at a crossover study, so these are the same individuals experiencing both treatments, and their average subjective usage of the oral appliance was 7 hours per night, using 98% of nights. The subjective CPAP usage was 1 hour less for 90% of the nights. But of course, in the case of CPAP, they could measure objective compliance, which was 2 hours less than the subjective compliance of CPAP. We too looked at compliance in our randomized crossover study using subjective measures for both treatments, and we found that MRD use was 1.2 hours higher than CPAP usage on average. An advance in the field has been the development of chips that can be inserted in the device to monitor compliance. And in this study from Belgium, they followed patients for 1 year to see what happened with oral appliance usage. And what they found was that 83% of patients were using their oral device for greater than 4 hours a night for greater than 70% of days. This is a threshold that's often used in North America to assess CPAP compliance, and that's why they use that definition. But the interesting thing here is that if you compare subjective oral device usage and objective, you see a very close correlation. For some reason, there is not that difference that is seen with CPAP. Finally, when patients are exposed to both treatments in a clinical trial context and you ask them which treatment they prefer, in a ratio of 2 to 1, they will prefer MRD compared to CPAP. And of course, some patients prefer either treatment or neither treatment. But MRD is overwhelmingly the preferred treatment. This is data from a meta-analysis looking at discontinuation of therapy, and the relative risk of discontinuation of MRD is half that of CPAP. So someone on an MRD is half as likely to stop using their therapy compared to a CPAP-treated individual. So then coming back to this holistic assessment of performance, how do we compare our two treatments? So in purple here, I have what I would suggest for CPAP. We have a highly efficacious treatment that can control the AHI, improve symptoms, provide health benefits, but it starts to deteriorate when it comes to adherence, tolerance, patient and partner acceptance, and convenience. In contrast, oral appliance therapy is here in yellow. You can see that its impact on AHI is not as great as CPAP. However, the symptomatic control and the health benefits seem to be equivalent. And the explanation for that must be due to better adherence, tolerance, and acceptance. So this leads to this concept of comparative effectiveness. In these squares is the sleep time vulnerable to disease. On the left, we have the case of CPAP, where the patients wear it on average for half the night, but it's very good at fixing the AHI. And so the shaded area is the amount of disease that has been alleviated. In contrast, on the right, we have oral appliance therapy that is not as good with efficacy, but is high on compliance. And the area of these two shaded areas is very similar. So it conceptually explains why the two treatments produce similar health outcomes. So having said all that, why on earth is there this barrier to oral appliance usage as the alternative to CPAP? And I don't know all the answers, but I suggest these. I think there's a general lack of knowledge amongst the sleep medicine community about how to engage with dentists to apply this therapy to their patients. The models of care can be a bit confusing, and so they need to be developed, and they're probably different in different countries and different regions. There is a need for acclimatization that can slow the process down, and so if you have a severe patient who's very sleepy or has unstable comorbidities, you may want to use CPAP because you can commence it quickly. The cost of therapy can be a barrier and lack of reimbursement as well. It doesn't work in everyone, and so we need to develop predictors of treatment outcome. I think physicians are sometimes overly concerned about dental side effects. Yes, they occur, they're usually minor and non-problematic. And we have limited long-term data, but in the next presentation by Professor Meurice, you're going to hear about some important long-term data. So I think the future here is more research, of course, large-scale studies. I would like to see more of a focus on moderate to severe sleep apnea with studies of at least 12 months, focus on cardiometabolic outcomes using state-of-the-art technologies and devices, and also to do cost-effectiveness comparisons. Thanks very much for your attention.
Thank you very much. I think we can have the questions after the presentation of Professor Meurice. So we will start now with the presentation of Narval CC. Narval is an MRD from Resmed, and Professor Meurice is going to show how interesting it is in terms of compliance and patient satisfaction. So I'll let you
Thank you.
go.
So first of all, I would like to thank the Resmed company for organizing this symposium and give us the opportunity to share with you the 2 years follow-up result of this study called ORCAD, whose goal was to evaluate the long-term efficiency and tolerability of a custom-made Narval MRD. As Professor Cistulli said just before, you know that all the MRD have not the same efficiency. And what I would like to show you, according to our result, is that the choice of the MRD is very important to obtain the best compliance as possible. In opposition to the herbs-like appliance, whose functioning is associated with a pushing compression effect, the Narval MRD is associated with a retention traction, which tend to close the mouth. This effect is associated with a reduction in the upper airway collapsibility and a better compliance, according to the fact that the pressure applied to the temporomandibular joint is reduced in this kind of functioning. The benefits of the traction-based articulation on comfort and tolerance can be summarized by the functioning as a physiological articulation, the decreased muscle strength and muscle pressures, and the promotion of mouth clouding and associated with a more physiological breathing. This slide illustrates the difference between an MRD associated with mouth clouding that reinduced a physiological nasal breathing, in opposition with this one, where there is a promotion of the mouth opening with an important impact on the upper airway and in the upper airway collapsibility by reducing the airway and the retrobasilingual area as on this slide. One of the features of the Narval MRD concerned is digital confectioning assessment which is associated with a computer-aided design and a computer-aided manufacturing that lead to a high level of customization with multiple design variation in order to fit the patient's special needs and the difference in anatomical function. Furthermore, the CAD/CAM process is associated with the minimization of the bulk of the device and the confection with the biocompatible polymer reduced the risk of allergy. As you know, the guidelines recommend MRD as a primary therapy for patients with mild to moderate OSA syndrome. However, there are very, very few studies who were especially assessed to evaluate the long-term efficiency and tolerability of this device in OSA patients non-compliant with nasal CPAP. Therefore, the French Health Technology Assessment requested additional specific clinical data at long term, 5 years, in order to confirm the efficiency, compliance, and tolerability of all the MRD actually reimbursed by the French health insurance. This recommendation led us to realize the ORCAD study, whose result of the first 3 months period of treatment have already been published in this article, and the 2 years follow-up result are actually under evaluation. ORCAD is probably the largest prospective longitudinal multicentric cohort study whose goal was to give information on the long-term use of the Narval MRD in the large population of OSA patients refusing or non-compliant with nasal CPAP. This study is still ongoing, including 28 French centers, and after the initial inclusion of 369 patients. Even if this study is very close to a real-life modality of use, the patient integrated at the beginning of the study polysomnographic and clinical data, as well as a dental specialist intervention in order to check the teeth integrity and to fit the custom MRD. The primary evolutionary criteria concern MRD treatment success that was defined as a more than 50% reduction of the initial AHI at follow-up. The secondary criteria also evaluated the rate of complete response defined as an AHI below 5 and below 10 at follow-up. And we also had the opportunity to evaluate the cardiovascular risk reduction by reaching a level of AHI below 15 in moderate to severe OSA patients. And finally, the clinical evaluation was based on the evolution of daytime sleepiness, snoring, sleep quality, quality of life from the baseline to the evaluation. And we pay special attention to MRD side effects and subjective MRD compliance. The 3-month polysomnographic recording demonstrated that 79% of the patients had a more than 50% reduction of initial AHI independently of the initial severity of OSA, and that an AHI below 10 was found in more than 60% of the patients. When we look at this result, according to the level of severity initially, we found that in patients with an AHI below 30, had a significant reduction of the AHI that was more and significantly important compared to the other patient. And in contrast, we found that the amount of change from baseline for the sleep respiratory disorders, as well as the clinical evolution, was more important in patients with a more severe pathology. Before to show you the 2-year follow-up result, I just would like to come back to the study design. As you can see, a total of 530 patients were initially screened. 215 patients were not finally recruited into the study due to decline or loss of follow-up or MRD contraindication. And at last, finally, 315 OSA patients were included and treated with Narval MRD. And finally, the 2 years follow-up evaluation has been done in 75% of the initial population included in this study. In this population, there was a predominantly male population with a mean AHI very close to 30, and 43% of them were considered as severe, while 50% of the patients were previously treated with nasal CPAP. The patient had a good dental and periodontal status as conformed to selection criteria, and the MRD was gradually adjusted at the beginning in order to obtain the optimal mandibular advancement. During the titration, after the first advancement of 2/3 of the maximal jaw protrusion, the mandibular advancement was adjusted at the discretion of the dental specialist in order to obtain the best benefit-risk ratio according to the tolerability and the symptom resolution. As you can see, at 2 years, MRD was still considered as efficient in 67% of the patient, independently of the initial OSA severity, with 57% of AHI reduction. As you can see, the reduction was significant after 3 months of treatment and was maintained significantly reduced at 2 years, with an identical residual AHI in 55% of the patient, an improvement in 14%, and we saw an AHI increase in 31% of patients, probably related in part of a relative relaxation of the MRD after 2 years of regular use. It's also very interesting to note that AHI significantly decreased in the 3 patient subgroup, particularly in the more severe OSA patient subgroup. When we look at the clinical evolution, we demonstrated a significant improvement as characterized by the significant reduction in the Epworth score, even for the height improvement of nocturia at 3 months that was maintained at 2 years, and with a continuous improvement of the Pichot fatigue score. These results were the same for the snoring evolution, with a significant difference from the baseline, and loud snoring was stopped in 90% of the patient. We found the same significant improvement in the quality of life when it was assessed with the Quebec Sleep Questionnaire. These results were obtained with a very few side effects. In fact, the main common events were the temporomandibular joint pain and gum pain. And as you can see, only 25 patients have stopped therapy for side effects. I just would like to insist on the role of MRD efficiency with very few side effects to obtain a good compliance and patient satisfaction. As you can see, and as it was said before, the compliance can be evaluated both by the mean duration of use each night and with the number of nights of use per week. In this study, the results were excellent, with a very nice compliance and a stable compliance over the time. We can really be sure of the reliability of this result because several studies have reported a strong correlation between self-reported compliance and objectively measured compliance. And this good compliance was also associated with a nice evolution of the clinical symptoms and also with a high level of satisfaction for the patient associated with a sensation of comfort and treatment efficacy. These results are comforted by this very short-term evaluation in European dental specialists who confirmed the very good satisfaction of the patient when the device was initially fitted, with a 92% of patients rated their device to be comfortable or very comfortable. According to our result, we wanted to select eventually some factors that could predict the long-term compliance with MRD. Here is the scale that was used during the study by all the specialists, the sleep specialists and dental specialists, in order to rate the benefit-risk ratio according to side effects and benefits. And as you can see, we found that 88% of the patients still have a high benefit-risk ratio at 2 years, with only 1.2% of the patients with a low benefit-risk ratio. Finally, we demonstrated that this high benefit-risk ratio confirmed by sleep physicians at 3 and 6 months was a predictive factor of long-term therapy continuation. These results are comforted by another study performed by another French team who demonstrated in 279 patients whose most of them were treated with Narval MRD, that after 3 years of treatment, the compliance was always very good, with 63% of the patients who were still treated by the oral appliance. And they found that the good continuation with the MRD treatment was related to the early reduction in HI and a complete symptom resolution at short term. So in conclusion, I would like to insist on the fact that Narval device is designed to provide high tolerability and efficacy to OSA patients, that long-term results from clinical trials confirm clinical benefits of Narval, as well on good tolerability and compliance, and maintaining these good effects at long-term follow-up. At last, this data reinforce the need for sleep physicians to get involved into MRD treatment follow-up. First of all, on a short-term evaluation on efficacy and tolerability to predict long-term compliance. Second, on the regular sleep study performed during long-term follow-up to control MRD efficacy. And at last, we recommend a regular dental examination to adjust MRD protrusion over time if needed. Thank you for your attention.